Son konuşmacımız Doktor Adonis bize kanıta dayalı tıp açısından BPH cerrahisinde enekülasyon yöntemlerinden bahsedecek.
Thank you again, Chairman, and thank you for the committee for inviting me to speak. Before I start this talk, I want to ask the audience actually, how many of you guys do any form of inoculation for prostate cancer, for PPH? And the second question, how many of you think that inoculation is the gold standard? Perfect, you made my life easy. So, as a form of disclosure, I am a fully female pelvic medicine practicing surgeon in the United States. So all my practice is on female urology, and although I'm a urologist and I did some BPH work earlier in my career, I haven't been doing BPH work for over 15 years. So when I got this lecture, it's like, it's interesting. I'm gonna be talking about something I have personally don't perform, but it gives me an opportunity as an outsider to look at the evidence and maybe together decide, is it considered the gold standard or not? So let's start with the lecture. So when I wanted to start this presentation, I looked at what is the definition of a gold standard. By the nice glossary, a gold standard is a method, procedure, or measurement that is widely accepted as being the best available to test for or to treat a disease. Nowadays, you use ChatGPT to write letters and to do everything. So I asked ChatGPT, what is the term gold standard in their definition? And ChatGPT answered, a gold standard is often used in medical, scientific, and other fields to refer to a procedure, a test, or a treatment, or a method that is considered the best or the most reliable available. So that's the ChatGPT definition of a gold standard. But then ChatGPT said there are criteria for something to be considered a gold standard. And here are the criteria. The gold standard should be reliable and accurate, should have established efficacy, widely accepted, it should have long-term data to support it, it should be a standardized procedure, there is a comparative superiority of the procedure compared to others, there has to be reviews and publication, ethical consideration, obviously consensus among the experts like you guys, and adaptation by clinical guidelines. So all of these together should fulfill for something to be called a gold standard. So went on the journey to evaluate the evidence. So the available energy currently for endoscopic inoculation of the prostate is, as you guys well know, holmium, thulium, green light, diode, and there is recently more forms of the plasma kinetic inoculation of the prostate and the bipolar inoculation of the prostate. But most of the data is available on a comparison of holmium and recently thulium, and some preliminary data is on the other form of endoscopic inoculation of the prostate. So with the holmium laser, the first studies showed in a retrospective review of 507 patients, stratified based on the preoperative prostate volume, found no significant difference in AUA symptom score, Qmax, catheterization time, hospital stay, complication, regardless of the prostate size. And in 2008, Kunz did a randomized clinical trial comparing HOLEP to open prostatectomy in men with a gland more than 100 milliliters, and they found there was similar improvement in AUA symptom score, Qmax at 5 years. And the HOLEP cohort had significantly decreased length of stay, catheterization time, blood loss and transfusion rates. And neither group required reoperation, and overall complication rate in the HOLEP group was low. These findings that were established earlier were echoed in multiple randomized clinical trials that followed. However, HOLEP was characterized by a steep learning curve, more than 50 cases in general, but in some cases some experts say you need at least 100 or 150 cases to become an expert in HOLIP. However, in experienced hands, it represents an efficacious and durable endourological alternative to open surgery and prevent multiple stage TURP procedures. Now, recently, this is a publication from 2023 on comparison of HOLIP to TURP in men with, it's a meta-analysis that was published recently. So they looked at all the studies, over 18 studies, randomized clinical trials on HOLIPs versus TURP. And you can see from here that the studies have variable number of patients included, and the duration of follow-up was also variable. So some of the bigger studies compared 140 patient to 140 patient, and the follow-up in one of this almost, and some of them were 2 years, some of them were 3 years, and one of them was 6 years. So in conclusion from this study, HOLIP was significantly associated with longer operating time, shorter catheterization duration, shorter hospital stay, shorter bladder irrigation time, and less post-operative irrigation. So that's some of the findings. As far as efficacy is concerned, the Qmax in the HOLIP group, there was higher Qmax detected at 12 months and 24 months, but it was not different at 1, 3, and 6, and 36 months. As far as the PVR is concerned, statistically significant difference was shown between HOLIP and TURP in terms of PVR at 1 month, 6 months, and 12 months, but there was no difference at 3 and 24 months. As far as the IPSS scores, at 12 months there was a significant difference. HOLIP was superior, but there was no difference at 1, 3, 6, and 24 months. Obviously, not consistent findings. The findings are all over the place depending upon the duration of follow-up. As far as adverse results, the results showed that compared with TURP, HOLIP was associated with a significantly lower risk of hyponatremia, obviously, blood transfusion, and urethral stricture, but at a higher risk of postoperative dysuria, as we probably all well know when you do HOLIPs. There was no difference in the incidence of recatheterization, urinary incontinence, retention, UTIs, reoperation, and transurethral resection syndrome, and postoperative fever between the two groups. The second meta-analysis that I want to review here is published from last 2022, and this compared HOLIP to bipolar TURP. A lot of my colleagues who do BPH who are not doing inoculation in the United States are doing bipolar. So this is 10 studies, and the 10 studies compared, as I said, the HOLIP to the bipolar resection of the prostate. And as you can see, the sample size, again, is limited from 60 up to 140 patients, and the follow-up, again, is mid-range, 24 months in general is the maximum follow-up in these studies. So this is the Qmax. If you look at the graph here, the Qmax, 6 studies, 6 randomized clinical trials compared 652 patients, included in the analysis of the Qmax. In the postoperative 6 months to 1 year follow-up, the bipolar technology and HOLIP group reported comparable Qmax, as you can see in the graph here, that it crosses the 0 in the first plot. When you look at the IPSS score, again, 6 studies with 638 patients included. There was no significant difference in the IPS score from the pooled data. When you look at the PVR, again, 4 studies mentioned the PVR. There were 468 patients. And again, you can see there was no significant difference in the PVR between the HOLIP and the bipolar TURP. If you look at the IIE5 score, 4 studies again reported IIE5 of 468 patients, and there was no significant difference in any of the IIP in these patients. Hemoglobin loss was significantly different, but there was a higher heterogeneity in the studies. A significant difference was shown by a random effect model between the HOLIP and the bipolar technology therapy. The mean difference was minus 0.48 in decreased hemoglobin loss. So the second form of energy that is commonly is being used in some centers is the thulium, and there are several randomized clinical trials comparing thulium laser prostatectomy to monopolar TURP, bipolar TURP, or HOLIP, have demonstrated that this technology is non-inferior in terms of safety and efficacy. These studies suggest that thulium laser may provide better hemostasis, less overall morbidity, and shorter hospital and catheterization time as compared to traditional TURP, as you will expect. As I said, some recent technology is using the bipolar technology for inoculation of the prostate. And as far as efficacy, there were 2 meta-analyses reported similar efficacy at 12 months in terms of IPSS, quality of life scores, and Qmax. Another meta-analysis evaluating the bipolar resection of the inoculation of the prostate to bipolar resection of the prostate reported similar efficacy at 36 months in terms of IPSS and Qmax. As far as our tolerability is concerned, the meta-analysis between the PK inoculation of the prostate and TURP reported a midterm IEF scores were comparable. Another meta-analysis reported less bleeding with the bipolar inoculation of the prostate compared to monopolar TURP, but similar rates of acute urinary retention after catheter removal. 2 meta-analyses evaluated bipolar versus inoculation of the prostate versus bipolar TURP, showed similar operation, catheterization, and hospitalization times, lower acute urinary retention, significant reduced hemoglobin drop, and blood transfusion with no difference in erectile dysfunction and no difference in all other reported complications. So what does the guideline tell us? This is from the European Urological Association guideline from 2022, and this guideline is on HOLIP. It summarizes that there is strong evidence that in mid and long-term efficacy is laser inoculation of the prostate, similar outcomes to TURP. As far as safety, short-term safety, it's similar to URP. Laser inoculation of the prostate with the HOLIP, with the holmium laser, demonstrates longer operating time, a more favorable perioperative profile when compared to TURP. So the conclusions and the recommendation from the AUA was offer laser inoculation of the prostate using the holmium laser to men with moderate to severe lower urinary tract symptoms as an alternative to transurethral resection of the prostate or open prostatectomy, and the recommendation level is strong. When you look at the thulium recommendation, again, they summarized the evidence and they said that the efficacy was compared to monopolar TURP, bipolar PK inoculation, HOLIP, and bipolar TURP in short and midterm and long term, respectively. The safety is also the same, and the vapor inoculation of the prostate using the thulium energy seems to be safe in patients with large prostate and those who are receiving anticoagulation or antiplatelet therapy. So the recommendation was labeled as weak, offer inoculation of the prostate with thulium to men with moderate to severe lower tract symptoms as an alternative to transurethral resection of the prostate, holmium, laser inoculation of the prostate, or bipolar PK inoculation of the prostate. And another weak recommendation was offer the thulium to patients with prostate receiving anticoagulation or antiplatelet therapy. As far as the bipolar transurethral inoculation of the prostate AUA guidelines, bipolar transurethral of the inoculation of the prostate shows favorable mid to long-term efficacy compared to TURP, as well as favorable safety compared to TURP, and the recommendation was to offer bipolar transurethral plasma kinetic inoculation of the prostate to men with moderate to severe lower urinary tract symptoms as an alternative to TURP, and the recommendation was weak. Now, the diode AUA guidelines, there was a practical consideration that the level of evidence wasn't strong enough to make a recommendation, and they recommended more studies on diode. Now, what does the AUA guidelines tell us? This is the AUA guidelines, and according to the AUA guidelines, if you look here on this pictured line, you will see that HOLIP and THULIP are considered as size-independent procedures, and you can see that they are recommended for all size prostates. So in the guideline number 38 of the AUA, holmium laser inoculation of the prostate, or HOLIP or THULIP, should be considered as option depending on the clinical expertise of those physicians, as prostate-independent option for the treatment of BPH. The second recommendation, as in the form of the expert opinion, that HOLIP, PVP, and THULIP should be considered a treatment option in patients who are high risk of bleeding, as you could see with the European recommendation. As far as the other form of energy, like we discussed earlier, the diode and other form of energy, the AUA recent updated recommendation said, published studies show promise with those modalities in the hands of surgeons that are comfortable in doing them. However, the studies are few to issue a recommendation. So the AUA has not issued a recommendation in support of other alternative therapy. So I go back to the first slide. Now, after this presentation, did anybody change their opinion regarding inoculation of the prostate? Do you consider inoculation of the prostate a gold standard? So based on my review here, since most of these studies compared to TUR and bipolar, I think it's being adapted more and more, especially in our country. We have two colleagues of mine who do, in my center, who do inoculation with the holmium, and these guys are extremely busy. My junior partner, who started 2 years ago, has done 400 HOLIPs in 2 years. And we send them all their patients who have BPH, who are enlarged and at risk. So from an outcome perspective, I think it is something that you have to have in your armamentarium, but is it considered the gold standard at this point? It's still, I think based on the evidence we reviewed, it's probably not, but some form of energy has more evidence than the other, and I think standardization of the energy and the technology is important for something to be considered a gold standard. So my opinion, based on my review of the literature, is it's not yet considered a gold standard, and but it is inching, and evidence is needed to be accumulated over the years. Thank you.
Çok teşekkür ederiz. Gayet güzel bir sunumdu. Sorusu olan değerli katkı verecek hocalarımız, arkadaşlarımız, iki hocamız da çıktı. Size bırakıyorum. Hanginiz arzu ederse o başlasın.
Çok teşekkür ediyorum. Eksternal sfinkteri önemseyecek olursak, üretral yolla yapılan HOLEP, şimdi bir kere dünya tersine evrimleşti. Enükleasyon tekniği Freyer ve hem ekstra kapsüler hem intrakapsüler olarak Milin tarafından geliştirilmiştir daha önce olmasına rağmen. Demek ki tersine bir evrimleşme söz konusu. Üretral yolla yapılan enükleasyonda yukarıdan, özellikle Amerika'da şimdi son zamanlarda giderek popülerize oluyor. Intravesikal, ekstraperitoneal, tamamen simple prostatektomi uygular şekilde prostatektomi enükleasyon yaygınlaştı. hangisi üstten yapılan tekniklerde mi, alttan yapılan tekniklerde mi eksternal sfinkterin korunması açısından avantaj sağlar? Bu konuda bilginiz var mı? Yorumunuz nedir?
So based on my review, and as I told you, I don't have the personal experience, but I have colleagues who are doing robotic simple prostatectomy, and I have colleagues who are doing the HOLIP. And based on my review of the literature, I didn't see any difference in the incontinence actually between the two approaches, whether it's simple prostatectomy or the HOLIP approach. I don't have a personal preference. As I told you, I'm a female urologist and I only see women. But if you're asking me about my review of our practice and the literature, both approaches are being done.
Adonis gerçekten çok mükemmel bir derleme. Kanıta dayalı tıbbı sunmak konusunda da ne kadar mükemmel bir konuşma olduğunu söylememe gerek yok. Benim tek sorum terminoloji üzerine. Siz de aynı zamanda bir scientist olduğunuz için bu gold standart kavramının ben doğru olduğu kanısında değilim. Bir tedavi standartsa altına ihtiyacı yok. Yani standart tedavi demek zaten standart yerleşmiş bir tedavi. Niye bir üst tedavi, bir terminolojiye ihtiyaç duyuluyorsa o zaman o tedavi standart olmamalı. Onun için bu gold standart kavramını ortadan kaldıralım bence. Standart tedavi diye devam edelim diye düşünüyorum. Ne dersiniz?
Well, I mean, we always, as a human being, want to emphasize betterness. So I don't know if a gold standard versus standard is something that is significant in clinical practice. But I do believe that, at least from a descriptive perspective, if something is considered a gold standard, it has to be provided with a lot of evidence, as you have this slide shows, to support that nomenclature. So if you prescribe something as a gold standard, it has to be a measure against which everything else is measured. So for inoculation to be considered a gold standard in BPH therapy, it has to be the anchor against which every new technology is measured. And it's not at this point. So is it a procedure that is available to certain select group of patients in your armamentarium? Absolutely. Over the last few years, as I said, we have specifically as a department went out of our way to hire specialists because there is not much of people who do inoculation in the United States. We've always wanted to seek people who have expertise in inoculation, so we have them in our department as faculty, and thankfully we have two now who perfect the procedure very well. I remember when I was a resident, this was 20 years ago, we did the first HOLIP, and I saw that this procedure is not going to take off. And now, it's really taking off really well and it's size independent, as you can see from the AUA guidelines. So, Francesco.
One short question. How do you see the future of these forms of enucleation when compared to robotic enucleation that is becoming more and more common among robotic surgeons?
So when I reviewed the literature, I immediately sent an email to my colleague who does the inoculation and said, it's time for us to write a grant for a comparative effectiveness type of study. We need to probably, since most of the big glands are being done either with whole lips or theolips versus robotic approach. In fairness, to answer the question, I think we should write an RCT that is for comparative effectiveness between the two approaches, and also cost effectiveness. Cost becomes a bigger issue. And some people, one of the advocates for bipolar inoculation of the prostate is that if you don't own a laser, whether it's a thulium or maybe that technology could be available for you. So where do I see the future? I wish I have a crystal ball, but I think the future that I see now is to go back home and excite my colleagues who do BPH to work with my team, my research team, to apply for comparative effectiveness trials and see if we can get funding so we can do a study that will help our patients.
Çok teşekkür ediyoruz.